my pleasure to be here. I want to thank the organizers, including the Public Foundation, Gilead Sciences, and others for hosting this event. My name is Alphonso David. I am a civil rights lawyer, and I'm the president and the CEO of the Global Black Economic Forum. We are an international enterprise that focuses on economic opportunity, economic justice, and economic freedom. And we do our work through global summits and conferences, through leadership development programs, through litigation, legislation, and policy development. We're really looking at deconstructing existing systems to create meaningful pathways to liberation for marginalized communities. And one of the key areas, of course, is health. We work with several healthcare organizations, including Gilead Sciences, to advance health equity. We have raised awareness about the importance, for example, of board diversity and how it leads to greater innovation, especially with respect to addressing disparities that affect marginalized communities. In addition, we have worked alongside Gilead to address the intersection of health equity and economic justice. Many people fail to see those connectivities. And we also joined Gilead recently in the Health Equity Summit held earlier this year. This morning, it is my pleasure to participate in a conversation about unveiling the hidden drivers of health inequities. And joining me for this conversation is Dr. Esteban López, Chief Medical Officer at Doxy.me. Prior to joining that organization, Dr. López held roles at Google Cloud and Healthcare Service Corporation, where he demonstrated improved healthcare services through strategic technology integration. He's a certified internist and a pediatrician, and he brings deep clinical understanding to his role currently. Further, he emphasizes his commitment to cutting-edge solutions, and he holds a certificate in leading digital transformation in healthcare from Harvard Medical School. Dr. López, please join me.
Good morning.
How are you doing this morning?
I'm doing well. Good morning, everyone.
How long did it take you to get through security?
Oh gosh, they gave us good instructions to be there at 8:15, and so security wasn't that bad when we tried to get through. But there was a group of us, power in numbers. We made it.
So this morning we're talking about health inequities and sort of unpacking it. And where I want to start this conversation is really at the foundational level. You have medical practitioners in this room, you have folks that work at pharmaceutical organizations, you have folks that work in the space that we currently refer to as health equity. Can you tell us how you think about this concept of health equity and why any of us in this room should care about it?
Well, first, thanks everyone for being here because this is such an important topic. I've had the pleasure to be talking about health equity, for over 10 years now. Way before people were talking about it. And people sometimes get confused on what is health equity, social determinants of health, health disparities. So just for the purposes of this conversation, and there are definitions out there, CDC has definitions, but health equity is really about the opportunity for everyone to achieve their highest level of health. The opposite of that is health inequity, is the fact that people don't have that opportunity, and often, in fact, it's unjust that they don't have that opportunity. Health disparities tends to be the differential in terms of preventable burden of disease or disease outcome in certain populations versus others. That is not genetically linked. And when we talk about social determinants of health, the social determinants of health are the conditions in which we live, either the social, economic, built environment, things like that that affect our health. And so it can get a little bit confusing because some influence others, but and oftentimes we think about this just in communities of color or marginalized communities, but did you know, for instance, that someone with serious mental health disorder, regardless of ethnicity, lives on average 20 to 25 years less than someone who does not have a serious mental health disorder? So If the life expectancy at birth is, let's say, 80 years old, for that individual, their life expectancy at birth is 60 years old.
So how do we get here? How do we get to this place that we're talking about disparities in health inequities? Can you walk us through what the history is? And I mean, we often hear about systemic biases within the healthcare system. Can you talk to us a little bit about how we actually got here, not only through a lens, a sort of a U.S.-based lens, but also a global one?
Yeah. Well, we know that there's going to be health inequity in every country on the planet. And oftentimes it is economically based. So for instance, let's say the gap between equity in Norway may be very narrow, but in the United States, it tends to be very broad. So we know that based on education or income, that your life expectancy or your disease burden will be improved. But again, the difference in some countries between life expectancy or disease burden will be very slim, but in this country, it tends to be very broad. And unfortunately, it tends to be very broad in disproportionately affecting communities of color, and even within communities of color, disproportionately affecting the Black community. So if we're talking about it, when we're talking about health equity, every country has its different reasons that there are health inequities. But in the United States, I would argue that the health inequities that we see here are built off of structural racism. The racism that is not ephemeral, that structural racism, be it the everyday microaggressions or macroaggressions that occur, those have corporal effects. They elevate your blood pressure, they elevate cortisol levels, they elevate inflammation. There's a weathering effect with regards to that. There's a cumulative effect. But it just doesn't happen from one day to the next. It happens because there are structures put into place, because you're asking why this happened. We can go all the way back to redlining, which affects education and things like that. People oftentimes will ask me, if I had a magic wand to improve health equity in the United States, what would I do? I would improve education. It has nothing to do with health, because we know that the higher education you have, the better health outcomes in a vacuum, the better health outcomes you tend to have, and the higher education you have, the more money you tend to make, and we know that the more money you tend to make in a vacuum, the better the health outcomes you tend to have.
And so we've heard this conversation. I know we actually talked about this last year at our summit, which was whether or not racism should be considered a public health crisis.
I would say that in this country, it shouldn't. It definitely should be considered, and the U.S. Public Health Association. The hypothesis is that racism is the #1 reason we see negative birth outcomes in Black women and prematurity and Black babies. And so, for instance, if I'll give you an example, and these are studies, and I'm happy to send them to you, but we know that women, Black women that come from Africa or the Caribbean, they have birth outcomes similar to white women in the United States. But in one generation, their daughters have birth outcomes similar to the general African American population in the United States. And we know that a Black woman in the United States with a PhD or an MD has a higher risk of a negative birth outcome than a white woman with no high school education. That a Black woman
I think that's worth repeating.
with an MD or a PhD has a higher risk of a negative birth outcome than a white woman with no high school education. And we see this time and time again. It has to do with the fact that women in general, we don't always listen to women, but we don't always listen to Black women especially. So, case in point, you've probably already heard this, I'm repeating it. Serena Williams, I would argue, knows her body better than any other woman because she is a top-level athlete. Serena Williams had a known issue with a pulmonary embolism. And she gives birth and is telling her doctors that she is not feeling well, and they delay the diagnosis of her PE. So if Serena Williams cannot get the best possible health care in the United States, what can we call for any other black woman in the United States?
So that's the problem. What's the solution? How do we really think about, in a holistic way,
You know,
addressing systemic inequities, especially when we're talking about this issue across class lines, right?
it is like boiling the ocean if you think about it, and it can be overwhelming. But I think the number one thing that we have to do is call it by its name. We dance around a lot of things in terms of, social determinants of health, which are important. We talk about, food deserts, which are definitely an issue. But we tend to ignore the point of care when the doctor is writing her order or his order or listening to their patient. That is also very important. And if we don't solve that issue, we're never going to solve the issue of health inequities. We have to do it at the time of care. And we have shown doctors, every doctor in the United States are trying to do the best thing for their patients. And every doctor will tell you that they treat all patients equally. Well, remember, equality is not equity. And when you show them the data, their own data, that you're not treating patients equally, that there are disparities, they don't believe the data. Black women in Chicago on the South Side get treated differently for breast cancer than white women on the Gold Coast. And so we have to, there are implicit biases, and there are, we have our blind spots. And I have those as a physician because I was trained in a structurally racist system. And I have to check my own biases. I'll give you a case in point. Right now, today, if you get a lab result, you have a normal GFR and an African American GFR. What the hell's an African American GFR? How black do you have to be? 50% of your genome, 25% of your genome? Because we know that if you present as black in this country, and maybe it's only 25% of your genome, you have all the negative effects of being black from a public health perspective. So we are othering populations on lab results. You're going to tell me that a 90-pound, 80-year-old black woman has a different GFR, which is an indication of renal function, than a 90-pound white woman? I'm going to diagnose her with kidney failure. So let's not call it an African American GFR, because the idea is that black folks have more muscle mass. Well, then let's make it a muscle density GFR. There's all these tropes today. There are studies where medical students think that black skin is different than white skin, that it's thicker, that it's more pain resistant. The only difference is the melanin. So we have controls for pulmonary capacity for black people in some of our studies or equipment. These are things that we have to change in medicine. It is 2024, and we still have an African American GFR. That is racist.
So you just alluded to, or at least not alluded, you actually explicitly said that our healthcare system.
I don't know if I was being direct or
explicitly
coy
said
about
our
it.
healthcare system is racist. which I think is appreciate that. For those that may have heard your earlier comments that mentioned socioeconomic status, mentioned gender, talked about the disparities along those lines as well. And talk about that as well, because I have another question after that.
Well, you know, I talk a lot about. I'm not African American. I'm not black, but I talk a lot about black health because even as a Latino, I know that we have health disparities, but it is just so glaringly obvious in the black community as opposed to other communities. But we see this also with women, regardless of gender. I mean, regardless of ethnicity, we underdiagnose heart disease in women. We believe women less. We have an expectation with regards to South Asians because they tend to be more vegetarian and things like that, that they're healthier. Well, do you know that South Asians have some of the highest incidence of cardiovascular disease that goes underdiagnosed? It is important for us as clinicians, as people in the healthcare field, to understand our patients. It is important to think of them as individuals. Race is a construct. We are genetically very different, like very similar. I will argue, yes, there may be genetic differences, and certain populations have that. But even when we talk about precision medicine and are studying genetics, we're not studying all populations. We're not studying the overexpression or underexpression of genes, the epigenetics associated with that. And so the genome doesn't tell everything because we're not studying populations of color with regards to precision medicine. They tend to be middle class white populations. But I talk about all of these things that are affecting both men and women alive or even before they're born. We're affecting black bodies before they're even born. And what we need to be able to do is, one, understand that it's not just about the built environment. It's not just about the foods that they eat, because we vilify people's diets and cultures. It's about the structure that the society is built on. I talk about how zip code is much more important than genetic code in the United States. Where you live will determine your health outcomes, not just because of all of the SDOH issues, but also because of the quality of healthcare that you will obtain. And it's important for us to understand that health equity is not just a black issue, or Latino issue, or a women's issue. It's all of our issues. Because guess what? If you live in a community that has a poor health equity score, it affects your life expectancy. People in communities that have more equity live longer regardless of race or gender. People that live in communities that are highly disparate in terms of equity don't live as long, are not as healthy. So you might think that because you're protected, because you're upper middle class or whatever gender you may be, think about the differences in your community. Is it an overall healthy community, or is it an unhealthy community? In San Antonio, where I live, we have one of the highest economic health inequities than anywhere in the country. About 20 miles between the haves and the have-nots. It used to be just a railroad track, right? And that was good because people mixed. They went to the library, they hung out together. But when you're 20 miles apart, you don't have that intermixing of resources, and that actually negatively affects your health.
So if you are a health practitioner here in this room, or you work for a pharma company, and you're thinking about, where do I start? Is there a domino effect? You've identified gender-based disparities, socioeconomic disparities, and focused on racial disparities. Is there one arena that you would suggest folks starting with that would potentially have a domino effect on all of these other disparities?
Well, as I said earlier, I think acknowledging that there's structural racism that affects people's health is the first thing. We dance around it. When I say racism on a stage, I hear gasps in the audience today still. You know, and we need to normalize the fact that racism affects your health. When we normalize that, then we can start solving for that. And so I think we oftentimes will talk about in this country how certain populations are at higher risk of disease burden. And so it's not necessarily that those certain populations are at higher risk of disease burden, is that being of that population is a marker for risk. Being black is a marker for risk. Being Latino is a marker for risk. It's not that you innately are going to have a higher disease burden. It's a marker that you may be discriminated in such a way that it will negatively affect your health. But I think that you're eating an elephant one bite at a time. Within your organization, pick one thing that you can do. Maybe it is, if your hospital system, no-show rates. Understand why you have no-show rates, and then address that. Understand, is there differences in the way that your doctors are practicing? Understand that. Pick one thing that you can actually change, and together we can then create a multiple effect. Because I don't have a magic wand to erase racism, and I don't have a magic wand to make everyone higher educated. But I can affect change either one system at a time or one issue at a time.
Parting words for the folks here, assuming that you do have some folks that recognize the importance of addressing structural racisms, addressing systemic inequities, but they don't have that buy-in internally. They don't have that support from superiors. What can or should they do?
They should get the data for their organizations and their communities. And data is data. I mean, the facts are the facts. There's no such thing as alternative facts. Right?
We're not talking politically here.
I've been saying in medicine too, there's no alternative facts.
The science is the science.
The science is the science. The data is the data. Find out the data, show folks the data, and come across with a solution on how to be able to fix it. Remember, this is about everyone justly having the right to achieve their highest level of health. It's something that affects everyone. And we know that health, I mean, we didn't even get into this, but health inequities has huge economic issues. I would say health equity and health inequity is not only an economic issue, it is a national security issue. Because if we don't have a healthy population across the board, we don't have a productive population. If we don't have a healthy population, how can we secure ourselves as a country from either be it in armed forces or things like that? And so we have issues with productivity, absenteeism, all of those things. The loss of life and the loss of years has real economic consequences. So if the moral issue doesn't change people's mind, maybe the economic issue will.
Dr. Esteban López, thank you so much for joining us. Thank you for your advocacy and your clinical work. Thank you.